haven't yet met, my name's Justine Bearden on behalf of myself and my co-director, Kim Ritchie. Sitting in the middle table there, we'd like to welcome you along to our event tonight. I'd like to also thank you all for making the time out of your busy schedules to attend, and also acknowledge the time taken by our panellists who I will introduce in just a moment. So tonight, obviously, we're here to talk about transformation. Eden Ritchie has gone through a bit about itself over the years, and unfortunately, we are extremely busy at the moment, and particularly in our clinical health recruitment division, and we're very fortunate to have added to our number of recruiters very recently with the addition of Monique O'Reilly to our team. Monique?
Oh, sorry.
So, welcome to the Eden Ritchie family. Monique joins us on our health recruitment desk. We've got a lot happening within the business, and in October we're off to the British Medical Journal Careers Fair, which we went to last year, which is aimed at sourcing scarce talent that we can't identify locally. So we're working in with a lot of particularly the hospital and health services throughout Queensland to identify critical clinical talent that can't be sourced locally. So if that's of interest to you in your organisation, please let us know. We've got a bit of a shopping list of different specialisations that we're on the lookout for. I'd just like to jump to introducing our esteemed panel now. Sue gave me a bit of a précis of their bios, but I actually don't think that does them justice, because I was reading them earlier and we've got a very interesting bunch here today, so please bear with me. I'll try and speed read this. We've got Terence Seymour, who is the Chief Strategy Officer from United Healthcare. Terence has a career that spans 40 years and he's worn many different hats. Leaving school at 14, which would be an interesting story in itself, he went on to become a draftsman to an underground contracting foreman before moving into HR. Along the way, Terence studied engineering, human movement and sport, and completed a Master of Administration at Griffith University, and is currently enrolled in a PhD. What's that focused on?
Organisational change and transformation.
From that high point to working as an assistant commissioner in the tax office, setting up his own business for a few years, Terence moved across to United Healthcare with the Sunshine Coast Private Hospital. He spent 9 years as the Director of HR, responsible for renegotiating all industrial awards and agreements and creating a positive working environment for employees. So there's a big transformational aspect in that piece as well that would be interesting to hear about. At the beginning of 2014, Terence became the Chief Strategy Officer, and in October last year led the groundbreaking project to open Australia's first fully digital hospital since Stephen's RBA. Terence is now part of the Griffith Industry Mentoring Program, which matches students with experienced industry professionals, helping them increase their understanding of their chosen profession. Thank you, Terence, for joining us tonight. Simon James is the CEO of the South Brisbane PHN. Simon explained why I say PHN perhaps later on. Simon moved to Australia from the UK in '92. I can't even really pick your British accent.
Really?
It's a bit of a comment.
Where he worked with the then Australian corporate icon May Nicholas. In '96, he joined the May Nicholas Healthcare Division as manager of Warners Bay Private Hospital in New South Wales. Simon worked with May Nicholas until 2000, and during this time managed hospitals in numerous metropolitan and regional locations, including Brisbane, Caboolture, Port Macquarie and Armidale. His experience in regional areas continued with the lead consulting position with Doha Regional Private Hospitals Program. In 2001, he joined APHS, a leading provider of pharmacy services to the secondary and tertiary hospital sector and the aged care industry. Between 2007 and 2012, he worked in cancer care and hospital services in South East Queensland. In February 2013, Simon joined the Greater Metro South Brisbane Medicare Local as CEO before transitioning to the role to the Brisbane South PHN from 1st of July 2015. Dr. Shane Kelly is the newly appointed CEO of Mater Misericordiae Health Services Brisbane commenced on the 20th of July, so fresh to the role. Welcome to Queensland. Dr. Kelly commenced his role as CEO of Marshall Health Services in July 2015. Prior to this appointment, he was the Chief Executive of North Metropolitan Health Services in Western Australia. Early in his career, after graduating with a medical degree from the University of Western Australia, Dr. Kelly worked as an intern, RMO and register at the St Charles Gardner Hospital. He went on to complete an MBA and Masters of Public Health and took on health service-based senior management roles, including Chief Executive of the Women and Children's Health Service and subsequently the South Metropolitan Health Service in Western Australia. Prior to joining the North Metropolitan Health Service, Dr. Kelly spent 8 years as the Chief Executive of St John of God Hospital in Subiaco. Dr. Kelly is a fellow of both the Royal Australian College of Medical Administrators and the Royal Australian Institute of Company Directors. His main professional interests are in relation to health, system performance and accountability and provision of safe, high-quality patient care.
Read them straight off mine.
I thought bio is really interesting. I'm kind of crazy about that. Last but not least, Bernie Harrison, healthcare leader and former executive director, National Hospital Performance Authority. Bernie is currently working as a healthcare improvement consultant. She has over 30 years' experience in healthcare, 15 years of that in areas of safety, measurement and improvement in healthcare. Her previous positions included Executive Director of Hospital Performance for the National Health Performance Authority of the Commonwealth Government and Director of the New South Wales Clinical Excellence Commission with responsibilities for improvement in blood transfusion practice across New South Wales. She was a 2001 Australian American Fulbright Scholar, professional awardee, and spent 9 months in the USA studying at Intermountain Healthcare with Dr. Brent James and with Dr. Don Berwick at the Institute for Healthcare Improvement. She project managed the Quality in Australia Healthcare Study, which was published in the MJA in '95. This publication was recently recognised by MJA as the most cited paper in the journal's 100-year history. She has a clinical background in neurosurgical intensive care and as a labour floor sister. She has clinical academic appointments at the faculties of Medicine and Nursing at Sydney University and provides lectures in quality improvement and patient safety in graduate and undergraduate programs. Bernie is an advocate of public health systems and has recent experience working as a volunteer in Kenya, sharing her quality and safety experience with not-for-profit clinics. So, tonight, thank you very much for coming. We started talking about transformation. I said to my team, it's a big word and it can mean a lot of different things to different people. I stumbled across an article that came through last week that talked about the Uberization of healthcare, which I thought was quite an interesting way of looking at things. It was by a guy called Stuart Carton, and it was through a LinkedIn feed that I got. And he was talking about, everyone was talking about disruption, and he was particularly relating this to the healthcare context and applying an Uber-like business model to healthcare. Obviously, the issues that stem around that is the regulation within the health industry, but he was particularly talking about the increased use of, for example, mobile technology. So, more and more people are starting to wear Fitbits and Apple Watches. So we're essentially starting to wear computers, and eventually they'll potentially be embedded in our bodies, and they'll be taking readings of our blood pressure and heart rates and weight and feeding them back to our doctors who can look at them remotely and possibly prevent admissions to hospitals and their flow effect of costs and that sort of thing. So I'm really interested to possibly hear from the panel about these sort of issues. And big companies like Apple, Samsung and Google are investing heavily in the healthcare sector and bringing in high-level expertise to break into what is seen as such a huge sector right from the picking. And there's a number of major US hospitals that are rolling out Apple's suite of health technology at the moment as pilot sites. Carton was talking about new startups possibly changing the healthcare model and moving from what has been traditionally, he says, hospital-centric to a more patient-centric model. I hear a lot of the work that we do, we work with clinical and non-clinical people within the health sector, And I think the underlying focus is that the patient needs to be put at the centre of all this, regardless of what we do. So I'm also interested, I mean, we talk a lot about our ageing population and the demands that we put on our systems, but I look at my kids and they are becoming, that generation is so informed and they can self-diagnose and, they expect to have information, they want to know the information, they want to be able to research the doctors, and I think this will be a growing trend of patients taking greater accountability for their own health care. So I just want to plant a few seeds of stuff that I'm interested in. It's all about me. Thank you very much for attending tonight. I'll pass over to Joe, who will be our MC for the evening.
For those of you that know me can probably not believe that Kim and Justin have given me a microphone, but they are. Thank you for coming, and nice to see you go through quite impressive panel for you all to pick your brains a little bit later. First we'll hear from each of them a bit of an introduction and an overview on tonight's topic. Before we get started though, I just want to quickly let everybody know that the restrooms are just behind you, those mirror doors, going into the lights. If you do need any top-ups on your drinks, there's one on the table, but the wait staff will be popping around with beers and more wine and water as well. So, ladies first, I think I'll hand over to Bernie to take the stage.
Thank you. Thank you very much. Is it okay if I don't use a mic?
Absolutely.
I've got a big voice. Thank you very much indeed, Ian and Richie, for inviting me to come along and talk. The guys had a brief discussion with me and they said you're content, so I'm content. Sorry, that's just in my eyes a little bit. So it's a pleasure to be here and to talk to you about a very favourite topic of mine, which is healthcare transformation. In preparing for this evening, I sort of looked up what does healthcare transformation mean. And it would be fair to say, depending which country in the world we're talking about, which system you work in, it pretty well applies to anything. It can mean role redesign, it can mean patient-based care, it can mean cost containment, it can mean quality and safety. So to confine this and make this a little bit easier for us to get our heads around, I wanted to specifically talk about some work that's come out of France. So it's the work of Professor Anthony Staines from Lyon, and he published in 2010 in the BMJ. And this is a great publication. It's been a source of many, many papers. Some of you may know Anthony Staines. He and I sort of tic-tac-toe and share papers and things. But it's been a very, very important piece of work that he has done and published. So what they did as part of this research was they set about identifying the most transformed hospitals in the world. So not just France or Europe, in the world. And I can tell you now, Australia doesn't have a single hospital in that group. So I'll just let you know that. I'll put it out there. The CEOs can address that. So they had an international panel, and the way that they evaluated these top performing healthcare systems in the world, hospitals in the world, was they looked at appropriateness, they looked at outcomes data, they looked at efficiency measures, they looked at cost, they looked at staff retention, they looked at safety, and there were about 22 hospitals that came up, and there were three that were the top performers. And those top performing hospitals, one was Intermountain Healthcare, and that's a hospital I know very well. That's where I spent my 9 months of my Fulbright scholarship with them, studying with them, and then over with IHR, so I know that very well. I was trained in their improvement method. I came back to Australia and I set up programs at the CEC and now nationally with AHHA. So Andrew's here, he's just left AHA or AHHA. But anyway, so that's an area of study and endeavour for me with Intermountain, so I know them very well. The other hospital is a hospital in Sweden called Jönköping, and Jönköping is a hospital that has specialised in microsystems. It started off with Brent James, it started off with the Institute for Healthcare Improvement in Boston, and it has gone on to snowball and snowball, and it is a stellar performer on any measure. The other one is Renier de Graaf Hospital, which is in the Netherlands. And Renier de Graaf is what we would call a lean production hospital. And interestingly, I've been working with the Australian Council of Healthcare Standards. We just did a review over the new build Royal Adelaide Hospital, doing an assessment around their quality and safety systems. And on the non-clinical service side, I actually met somebody from Renier de Graaf who had led part of their lean production on the non-clinical service side into the clinical service side. So what Renier de Graaf is an end-to-end lean production all the way through push and pull systems. It has a single discharge team for the entire facility. It's awesome. It's just absolutely awesome. Anyway, so that's that system. So they looked at these systems and they did their study on the positive outliers. What was it about these facilities, what were the attributes of these facilities that meant they were able to transform care? And when I'm talking about transformation of care, I'm talking about moving away from silos, moving away from specialty-based care, looking at patient disease group, but patients as disease continuums, not as a heart or a lung, but as an elderly patient with complex medical conditions. How do you organise care in that way? That's what these systems are really good at. Number one on the list, and I kind of know this because I learned this in 2001, but it still applies, is that these organisations, the 20 and these 3 top performers on any measure in the world, they have a culture of improvement and they have invested in capacity building of every frontline clinical staff member is trained in how to in improvement science. And I know that when I was in Intermountain Healthcare because I sat in all those training programs. That's what they do. They have organisations of learning. And what that means is they have developed feedback loops to the clinical work of the people that work in the microsystem, feedback information, they get real-time feedback information that allows them to continuously improve. They use statistical process control charting as part of the improvement science. They develop clinical leaders and they train them in teamwork. Some people here from the Cognitive Institute and they're specialists in that area. Because what they recognised is that just being a clinician, a haematologist, a surgeon, doesn't mean that you have any training in how to be a clinical leader and a leader of people. It's a completely other skill set. When I was at CEC, I ran a leadership training program there for 7 years. So many senior doctors said to us, oh my God, I should have done this 20 years ago. It would have made my life easier. I'd probably still be married. The other thing about these organisations is that they have been able to keep a focus on improvement during the crisis. So whatever the crisis is, bed block, bed shortage, hot topic from the Minister's office, whatever that is, they have managed to stick with their original improvement agenda. Very, very important. These organisations have also identified that there is what's called an investment threshold in quality improvement. And what that means is it will take you 2 to 3 years to build the capacity in your frontline staff before you start to see measurable improvement. Now, I did a stakeholder analysis, stakeholder gap analysis when I was at CEC. We spoke to chief executives and we said, what would you like to see in the improvement agenda? And they just said, well, it's a load of rubbish because we sent a few people to do that course. We didn't see any improvements. We're not sending any more. So what these organisations realise is it's going to take time to build up that capacity. Brent James has always said to me, it's the square root of N. Whatever your workforce is, get to the square root of N and you'll start to see a change in the culture. It takes a while to get there. And importantly, with that in mind, it's the consistency and the stability of leadership. And all of them in the BMJ article have been at this for 15 years. Now you could say that's generational change, but 15 years it takes to get without a churn in leadership. And I go and work with hospitals where the CEOs change every year, and it's impossible to get change. Now, interestingly, that article came out, it's been published, there's been a lot of talk about that, not necessarily in Australia, but certainly in the European and the American countries. And the NHS back really picked up on this big time. It's a very, very good publication, and it's called Learning from the Best, What the NHS Needs to Do to Deliver High Quality Care for All. So you can just Google that, download that, it's a very easy read. It's been written by a guy called Chris Hand from Birmingham University, Management Centre, University of Birmingham. And the NHS identified a series of things around top performance. So they took that original research from Leon, and then they put this into a paper, and they said to organisations at a national level, go away and do this. Now, a number of organisations picked up on this. In fact, loads in the NHS, but I'm going to highlight a few. Firstly, Scotland, the Scottish NHS. They have run a programme called the Scottish Patient Safety Programme. It is phenomenal. It is fantastic. They have managed to take clinical KPIs, ventilator-acquired pneumonia, time to thrombolysis for acute coronary syndrome, unexpected deaths by DRGs. They have linked that to, as KPIs to CEO performance. So as a CEO of those organisations, if you fail on those measures, you're wrong. It's not about efficiency. It's not about how many widgets can we get through, how many patients are waiting on the wait list. They changed, they flipped the whole thing around at country level. Very impressive. The other hospital, I spent some time with them in February, is Salford Royal Infirmary. And they are very dear to my heart because my mother was there, she was diagnosed with a brain tumour and they took care of her till she passed away. Well, we did the care at home with them as an outreach. Salford Royal Infirmary right now is topping every prize, every measure across the whole of Europe right now, in every way that you could think to measure it. And what Salford have done with David Dalton, he just received a knighthood, so David Dalton. So through the work with David, and he's been a CEO there for 10 plus years now, David has created an improvement academy within the facility. That's headed up by a lady called Maxine Power. And they have a KPI, a board-led KPI, that at 3 years, 70% of their frontline staff will be trained in improvement methods. And at 2-year mark, they have 50% trained. And I did rounds with them in February, and the work that they're doing, it's absolutely phenomenal. The redesign work, the change they've incorporated in neurointensive care, where I was a neurointensive care assistant. They have managed to get an outpatients department within the intensive care unit because it's better for patients. And David Dalton was around and goes, good on you, I want more of that. I want more of that. Fantastic. It just absolutely took my breath away. The level and the amount of work that they're doing in improving. So, in our region, the only place in our region that does anything that looks anything like this is Middlemore Hospital in New Zealand. And they have created an improvement academy, if you like, and it's called Aotearoa, which is the New Zealand work for first. I'm a member of faculty with them around their safety training. And they are training their frontline staff in improvement science. They are leading collaboratives, and they are particularly working in transitions and continuums of care, particularly across minorities health, amongst the island community there. And the work there is fantastic. They have a national conference, it's on in September. I would strongly recommend you go. The Salford team will be there presenting on their work. So if you haven't seen any of this stuff, you need to get up to date and see what they're doing. Both Aotearoa and Salford are emulating the top 3 now. Quality academies, training for frontline staff and improvement, with extremely ambitious targets at that 3-year mark to get to 80%. Leadership development, teamwork, a lot of the work that our colleagues here from the Cognitive Institute run, that is part of that investment. Patient-led care and redesign, particularly around ageing population, chronic complex disease. Role redesign, huge, absolutely huge. Why have you got pharmacists who are not prescribing in your emergency department? There's published literature that says they don't make any mistakes, and junior medical officers make hundreds and hundreds of mistakes. It's not safe. So people have really critically looked at this around that safety stuff. And then getting those clinical outcomes aligned with board goals. My own observations of all of this, having spent 15 plus years of my career looking at this stuff, if the business transformation is not led by the CEO and the board, it does not happen. If the CEO is not a strong advocate of quality improvements as a business model for the organisation, this will not get off the ground. Australia, I'm going to be provocative now, Australia is losing ground massively to the best in the world. We are entirely focused on compliance and regulation and root cause analysis and recommendations without any focus on improvement. And the role of improvement belongs to the organisation, not government, not government. Unless we transform and we learn to transform and we learn these techniques, we will continue to have unacceptable rates of harm, which we already have, widespread variation in cost, the frequency and outcomes in care. I was the Director of Hospital Performance, Executive Director of Hospital Performance for 18 months in HBA. The degree of variation is staggering across the system. We will continue to see low levels of patient and family satisfaction. We will have a lack of implementation of evidence consistently across the health systems, which we already have. We will see high rates of ineffective care in a fee-for-service model. We don't get on top of it. And we will have an inability to manage safe transitions and hospital avoidance for the aged population. And do we have an urgency? We have a big urgency. We have an aging population described as a tsunami. We have a GFC. China are going under. We're not watching the news. The cost of new and emerging technologies will absolutely cripple us. Global warming, pandemics, just to mention a few. So, the transformation challenge is on. It's urgent, it's pressing, and we need to get up to date with best practice in the world. And it's there, it's documented, you can see it, you can email these people, and they can email you straight back. So there's no excuse. That's it.
Thank you, Bernie. Are we going to move around and check on the slide next?
I'm not quite as well prepared, obviously, what I've written down, but I'll just a couple of thoughts, if I can move straight to the provocative. In many respects, I think our healthcare system in this country is excellent. We have one of the longest life expectancies in the world. And this is in spite of the fact that we don't look after our Indigenous population as well we might. I guess the bigger challenge for us is that whether or not our health system is sustainable, and I don't share the view necessarily that we should invest our time and effort in hospitals and secondary and tertiary healthcare. I think in some respects that's investment in a service that is a recipient of a primary healthcare system that perhaps isn't working as effectively as it might. The unit cost, on the other hand, of care in the community is much less, and I think that's where we have to spend our money. Now, there are a few challenges in changing the way we deliver healthcare in the community. We have a funding structure that doesn't recognise payment for outcomes necessarily, and indeed does feed the hospital system. One of the easiest things for a general practitioner to do is to refer patients into a secondary anything at all. If we're to have transformation in this country in terms of the way we deliver healthcare and to ensure sustainability of the healthcare system, then our investment has to be in primary healthcare and the people who deliver care in the community. And I'll be happy to take some questions on that.
Thanks, Simon. I think Simon's helped to let me off the hook for being as ill-prepared as he is. My understanding was we were going to have a question and answer session, and I ideally hope we have plenty of time.
We don't do that.
So we'll get there pretty quickly. But I'd like to say that I don't agree entirely with what Simon said. I think we do need more in the space of primary care, much more, and hopefully leading to a reduction in requirement for services in the expensive hospital sector. But in our lifetime, there's still going to be busy hospitals, acute care hospitals, and we have to learn to do what is necessary to make the business model work for the patient. And I think Bernie has really given us a great outline of where things are at the moment, really thrown down the challenge to us all. Absolutely right about the fact that Australia is not on that map at the moment. Plenty of organisations in Australia, I think, are starting to hear from and learn from those that are getting it right now in overseas. The Intermountain Healthcare of the world, and I guess you wouldn't be a good senior executive in health in Australia if you didn't know a bit about Intermountain Health and their experience. But we need to really learn from that or be left behind. A combination of that focus with the technology and all the pressures on us mean that we can't keep doing what we're doing now because that's just a business model that will not be sustainable in the future. So, and I think the point about stability of leadership and having the right KPIs for that leadership are really important here. And to come in to an organisation and just be focused on the efficiency is going to miss the mark, as Bernie has very clearly articulated. And I think one of the things that we constantly need to continue to do is dispel the myth that there is a clear association between efficiency gains and quality and poorer quality outcomes. It's the complete opposite, and I think everybody that has really travelled this journey, and those of us that have at least in part travelled that journey in organisations that we've worked in, have been able to demonstrate that one goes with the other. It's not the reverse. And if you therefore set up the CEO and the senior executive to be focusing on the clinical outcomes for the patient and their families and delivering what they need to have to make it a safe model of care, then the rest will follow. You need to work at it, you need to do all that back of house stuff, but it ought not be the point at which you begin that journey. So I think I'd like to particularly thank Bernie for laying down this challenge for us tonight, and I'm happy to take any questions about my experience in relation to the little bits that I've been involved in transformation.
I think there's a few people here that have a couple for you, but let's just quickly hear from Terence first.
Quickly hear from Terence. My family will tell you that's impossible. I'll try not to do it. Bernie, thank you very much. I think the information that you presented was stimulating and challenging. I do think, though, from my perspective, you're a little harsh on the Australian context. So I can point to a number of organisations where there is a direct link between the CEO's performance, their salary, the clinical outcomes that are expected, that are being driven by boards. So I think that conversation has at least started in Australia. I agree with a long way down. It's always interesting to go last to see what we all thought about in terms of organisational transformation, or the impacts of organisational transformation. I would say, sitting here tonight, that I think it's a bit like strategy. It's one of those really oft-used terms that nobody really knows what it means. So, it sounds good. When we get to a meeting, we're going to do some more organisation, we're going to transform. And I guess my view on that is that if we are talking about transformation, for me, transformation is not that smaller change management stuff that you do. Transformation does have a component if you're in Queensland Health at the moment. The move from Queensland Health to Hospital and Health Services was a transformational set of activities. The work that goes on in organisations to move from paper-based to digital health is a transformational activity. It fundamentally challenges some of the underpinnings of how we've gone about our work. For the surgeons, the move from actually knife to skin to remote technologies that allow you to provide care to someone who is literally thousands of kilometres away is transformational work. And for those of us who sit at our desks and do other work, the capacity to get 28 hours out of every 24-hour time period, which is work that's happening in other industries, is a transformational piece of work. So for me, transformation is about how do you engage around that. I guess the next issue for me is about, so how do we judge organisational transformation or transformational improvement? It depends on what we're trying to improve, and it depends on what we're trying to drive. Will it work if it's just an organisational restructure? It is unlikely. One of the key things that I take out of the research that Bernie's presented, and my colleagues have said also, it's absolutely true. It is about the people. It's about the culture of the organisation. It's about what you have to drive first. And if you want transformation to stick, and I know that's one of the questions that's already been written into us previously, transformation to stick has to be about the people. And for me, that's about, it's about accountability, it's about performance management. I guess fundamental to delivering safe and quality healthcare is that organisational culture. It has to cover everything from, is it safe to report this? If I see my colleague and I suspect that they are under the influence, or that they are fatigued, or they are undertaking some work in some way which places the patient or their peers at risk, do we have a culture that enables that to occur? Do we have a system that enables that to occur? Is it encouraged? How do we support it? There's an old adage which says you can make the best systems in the world fail with the wrong attitude. And the reverse is also true. You can make the worst systems in the world work if you have people who are prepared to contribute and make it right. I guess my view about the current financial circumstance, and I absolutely agree that it's an interesting period coming up, it will have an impact on how we transform our industry. But I think it'll have an impact primarily on the what we do, not the how we do it. So if there is a tightening of the financial environment in which we work, it will slow down the adoption of EMRs across Australia. How long have we been chasing an electronic medical record now? And what will that bring to us? But you know, the business case for that at the moment is just not looking pretty for any of us. It'll slow down the adoption of remote technologies that we've mentioned before, and the supporting mechanisms that go around. It'll slow down the purchase of particularly new and emerging technologies, and the debates that you're seeing at the moment within the broader media around health funds and health service providers about what will and won't be paid for. As that contracts, then the capacity of the treating physicians to be able to move to something new. Part of the research that I'm doing is a view that says, there's a hypothesis that I'd like to explore, which is about why is it that this industry is so slow to adopt emerging technologies. There's all sorts of responses to that, which might be about a legal framework or, you know, gold standard treatments and all the rest of it. If you're a bright young engineer in Lithuania and you decide there's a new way to build a bridge, the bright young engineer in America or China or Canada will know about that and be exploring that and looking at it and implementing it much more quickly than a bright young surgeon who's discovered a new way to do something with our bodies that needs repair. So I would say in terms of bringing about organisational transformation, it is about cultural change. It has to be driven around people. There are strategies to overcome some of that, and I'm happy to talk about those later on. But I would say right now we are at a point, we do need to make some changes, some fairly radical changes, but that happens across the system. I noticed my colleague Glennis Webby from Blue Care's sitting in the front table waiting to ask me all the questions, but if you think about the commentary that's already been made, whether it's primary health care, that's the service delivery, or whether it's that transition care that Bernie was talking about between how we treat a patient for their whole care continuum. You know, that capacity at the moment within our system to care for a person from community to secondary or tertiary or quaternary care back into community fails miserably. And that's partly regulatory, it's partly service provider. So on that basis, I don't stop.
Thank you very much. Is that 70% of change initiatives actually result in failure? So I'll turn back to you, Terence, and ask, you know, what are some of the things you think we can do potentially to reduce that risk of failure?
I'd like to slightly correct that figure. The figure, the research actually says 70% of them fail to produce the expected results.
Okay.
So they do fail, but it's not that they fail completely. And I think there are a couple of answers. Where I would start was with the square root of n. I think it was n squared that you said. As part of my background, I have been lucky enough to deliver cultural change programs or organisational change programs right across the world, excluding Africa. And my answer, partly to your question, Jade, is 13%. 13% is a rough figure that you will need. If you're doing a $100 job, you need 13% to manage the change component. You need $13. If it's a $1 million job, you'll need about 13%. Why do I say 13%? That's simply what the research tells us, that if you are undertaking a major organisational change activity, if you allocate 13% to deal with the cultural change, training, communications, all of those types of activities to bring people along. When the question is how do you make it stick, you've got to be able to answer the old question of whipping. What's in it for me? You've got to be able to answer that question at an organisational level, at a team level. What's going to happen to my colleagues here? Are they keep their jobs? They're not going to keep their jobs? What's going to happen to me? So you need to be able to answer that very, very, very clearly for all people across an organisation. That's your start point, I think.
Excellent, thank you. Turn to the floor. If anyone has a question, you can just pop your hand up. If you need the microphone, I can bring it to you. Surely not that many shy people in this room.
I'm probably going to...
I was going to say, I don't think Ross needs this.
Bernie, Ross Hetherington, I'm a GP in Warwick and on the hospital board and a few other things. I was interested in your comments about pharmacists in A&E and CAS, make less mistakes than junior doctors. We realise that now. In general practice, we use pharmacists now to do home medicine reviews, aged care, medication reviews and stuff like that. So are you talking about you have a senior doctor that diagnoses something and then the pharmacist reviews everything, or the pharmacist diagnoses and then prescribes, or because I come from the part of the country where we're using nurse practitioners more too, so
Yeah.
I'd like to know how they would fit into your model.
Yeah. So, so the way that if I just talk more generally around the improvement approach to this, rather than the specifics, because I probably won't be as across the specifics as you are. But the thing that systems have done, and a lot of this work's been led by a company in the US called Washington Associates, and they did a lot of work in the NHS. And so, for example, they had a group of general practitioners, and they said to the general practitioners, really like yourself, they had a seminar, and they said, what are your problems? And the GP said, oh, there's too many patients, we don't have enough time, you know, blah, 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 blah. This is, you know, the list as long as your arms, you know. Patients present later, sicker, can't get into hospital, etc., etc. So the Improvement Associates, this company, and they are engineers, they're system engineers, they're not hospital trained. They asked a really, really important question, and this question pretty well galvanised improvement under the Blair government for the next 15, 20 years, because they asked the question of the general practitioners, is healthcare always a visit? Is healthcare always a visit to a general practitioner? Is that the only way you get healthcare? So that's the first question. And of course they said, well, no, because if you ask the community, they say, well, I go online, I talk to my friend, I read a magazine. There's lots and lots of ways people find out information about their health. Watch embarrassing blogs. It's amazing. So, you know, that's how people are finding out about healthcare. Right. So that was the first question. The second question was, who else can deliver that care safely? Is it only a doctor? So if you're talking about complex cardiac surgery, then it has to be a technically trained cardiac surgeon, right? Particularly if you're doing it laparoscopically. However, if you've got pharmacists, if you've got experienced nurses, and you ask the question, who else can do that care safely? So for example, in the UK now, it's a standard. Chemotherapy is only prescribed by a pharmacist, not by a junior medical officer. It's too dangerous, it's too risky for patients. And so the patient safety concern has trumped the professional concern, which is what people would say is correct. Now, McKinsey's in the UK did this very interesting review. This was published again, and this was led by Professor Aradazi, Professor Lord Aradazi, that at Imperial College. And he got McKinsey's in because the question was, why has the improvement agenda been so slow to get going? Why are we still struggling with it? We keep talking about it. We've got 100 years of improvement in other industries. We know what to do, and yet we haven't got it in healthcare. So what they did was they went back to that cultural question. So McKinsey's juxtaposed pilots and doctors. Okay? And they said, they interviewed a whole bunch of pilots, and they said to them, what is the dominant culture in your organisation? And the pilots said, safety. Every single one of them. When they asked doctors the same question, what is the thing, the dominant culture in your organisation? Firstly, they didn't know what they were getting at. And then they said to them, well, what's the thing that bugs you the most? What's the thing that is absolutely forefront in mind when you come to work? Walking? My list? My clinic? It wasn't safety. So, Aradazi, who is a surgeon, pioneered laparoscopic simulation. He said, we have a cultural problem. The reason this has been so slow, and people like Brent Jones say, and I've heard him say it, in big meetings and to roomfuls of clinicians, doctors, nurses, allied health, he said to them, you will trade clinical autonomy. You will need to give that up for improvements in care. And it's a trade. And you need to be prepared to trade it. Because you can't, it's a craft-based practice, and it's without running. That, 100 years ago, hospital care, yeah, we could get get away with it, they have 4 or 5 things you could do, most of them involve leeches. You know. And now it's different. So, to go back to your question around the whole role redesign piece, this was led by the Blair government. Tony Blair was going to lose the election over the NHS, waiting list, waiting time. He went to the colleges. He asked college presidents to lead improvement in how we're going to manage capacity and demand, particularly around wait times and wait lists and procedures. And these were things like carpal tunnel, these were things like lens, ocular lens, common scopes, endoscopy, colonoscopy, etc., etc., etc. They brought teams of doctors and nurses and our health professionals together. These were teams that knew each other, they were used to working together, and the surgeons went, oh, God, you know, I trust my scrub nurse who's worked with me for 20 years over a resident. God, you know, he or she can do that. And so I was here 7, 8 years ago in Brisbane, and there was this fantastic gastroenterologist from England, and I was on the podium with him like this, right? So I'm there, I'm doing my health improvement, rah, rah, rah piece. This guy stood up, it was a gastroenterology conference, and he stood up and he said, this is what gastroenterology care looks like in the NHS. And he started talking about how he had nurse-led endoscopy and colonoscopy clinics, and he had the humility to say, and I can tell you, I no longer have the best results in my department. Meaning his nurses are doing better than he is because they're doing more. Well, there was a gastroenterologist, it was your big stadium bus, from the back of the room, and I was loving this. This is so cool. He came marching down to the front when they said, any questions? Well, he came flying down the room. I mean, there was no holding him back. He got to that point and he said, that is the most preposterous thing I have ever heard. That will never happen in Australia. He wasn't the green line. He said, that would never be tolerated in Australia. Whereupon, and I trained in the NHS in internal accent. I mean, it's just so shocking to me. But the NHS has transformed this much from when I trained, where nurses had to trail behind doctors and, you know, look down at the ground, and there were separate sitting rooms and the whole works, and it was just terrible. That's how old I am. And this, I have to act this out for you. This gastroenterologist, just looked at this guy, and he leant laconically onto the podium. And he said, he looked around at everybody and he said, I think I need to let you know something. And they went, what? And he said, you do realise that technical performance is not linked to professional background. And you could have been involved. It was like, oh my God, that might be true. Because technical performance is about practice and repetition. Now, Aradazi's done the work in Imperial College. He pulled in Joe Public off the street, wandering outside Imperial College. He got medical students, he got experienced surgeons who were not trained laparoscopically. He ran them through his simulator training. Who do you think did the best? People off the street. It made no difference. There was a number of hours that you have to do to develop competency, like learning to play a musical instrument. It's practice and repetition. So this idea, you know, and the thing that England and Europe are grappling with is the monopolies by surgical colleges. Now I'm getting in the area now of where I don't need to go, and get out of here alive. But, you know, if we're talking about transforming a healthcare system that is protectionist, self-interested, doesn't prioritize safety over everything else, doesn't, you know, our chief execs here, we've got 2 here, this is a big job. This is a big job to tackle, to take on. But, you know, we're all here and we're cheering, aren't we? Yes. We're cheering from the sides because we know this has to happen. We know this has to happen.
I totally agree. In our country, you know, we have our gypsies too, our GPs that do the scopes and the colposcopies, everything like that, just like the UK does. And we are trying to train up nurses in our HHS to do endoscopies. We're having a little bit of pushback about that.
Yeah, no,
but I mean, once you get away from the big metro areas, you know, the the patient care becomes much more important, and the GPs are much more important, and it's the team, it's the primary healthcare team.
Quite frankly,
So-
you know, my view is rural health Australia, rural remote health, will teach the rest of us how to do this, because you don't have to do it. It's like developing countries. We learned that nurses and technicians could do intraocular lens tracking because of India and because of the work of psychologists. That's how we learned it. Because when you have that many people affected by blindness, and that is, you know, I care for a blind child at the weekend, that disability is so profound. And the dependency that causes, and a lack of income, and blah, 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 and brain damage. You know, the idea that you can restore sight, but we're going to wait 10 years for specialist training, what for most? Of course we're not. We can train 10 people technically to do that. Why wouldn't we do that? Why wouldn't we do that? Carpal tunnels are done by nurses now. Of course, I talk to nursing groups. The nurses go bananas with me. I mean, the room takes off. Oh, that's just more work nurses have got to do. By the way, registered nurses in the United Kingdom and in America do not toilet and bed bath patients, and I'm not saying that that's not an important job. It's just that you cannot expect to be a university graduate with a degree, with that degree of salary, and think that's your job. It's not reasonable anymore. So,
I think these two could definitely have a few wines and debate that.
I'm not going to upset anybody who's a theatre nurse in here, but frankly, you do not need to be an RN to be a theatre nurse. And we still live in this paradigm of we have shortage because we don't have enough people that have gone through this progression. We should be training people through the, you know, as technicians who are eminently capable of providing those services to you. But boy, you come up against some union opposition.
Well, we don't want anyone marching up the front opposing anyone, but we've got a question from Esther at the back there.
I'm Esther from Metro South. I just wanted to ask a question about adoption of quality improvement when we don't have the financing model for it. So, as you said before, we're in a fee-for-service model, taking some tentative steps towards national efficient price and all that kind of stuff. But until we move to more to the supplier side, cost-sharing model, or quality incentives like they have with the PRIP program in the UK, do you not think that that's actually going to hinder people a wider adoption of quality as part of our daily business? Because it doesn't really work with cost-sharing with fee-for-service. With economic quality.
If I understood your question correctly, it's will the lack of a financial incentive hinder the adoption of quality?
Well, under
My words, not
yeah,
yours.
I mean, the evidence internationally is under fee-for-service. It's very, very slow to progress with quality, and all these systems that move to more supply-side cost-sharing between providers and purchasers of care, the quality is incentivised.
Sure. Happy for the rest of the panel to respond as well, but my view is knowing the quality and not to insult the whole room, but knowing the quality of managerial excellence in Australia is not where we want it to be generally. It's probably a true statement that you've just made. My challenge to myself, to my teams, and to you, I guess, is I don't believe that needs to be so. You can adopt quality improvements that actually save you money, which fund the rest of it. You could ask the question, would you, of anybody, would you purposely do something which hinders the well-being of the person in your care? And the answer, 99 times out of 100 or more, is no. And so if you start to design your improvement programs around a cultural shift, and I will bang on about this probably until the day I die, but if you design your improvement programs around the engagement of people, the adoption by them of an idea and a concept, it doesn't need to be as slow as it is at the moment.
I think it's horses for courses. I think there are some things that work reasonably well under a fee-for-service model, where you can make sure that the incentives are properly aligned. Certainly not the case for everything. But I don't think we should be starting, as I was saying, with the assumption that someone's going to seek to do something adverse because of the financial incentives. But having said that, there's plenty of evidence around that there is significant variation between what we do to people with certain conditions, and I think we need to be very conscious of that whenever we're constructing a model that has a fee-for-service element in it. It's not evil. It can work in certain circumstances. It can drive efficiency, but you've got to make sure all the other levers are in place, and your focus is again on safety and quality.
One thing I was just going to say, from a primary health perspective, the focus does need to change. Almost any aspect of primary care currently is focused on a sum of money per unit of process, and that's where it seems to begin and end. And it really the focus needs to change, obviously, to outcome-based payment, so sustainable outcomes for a patient cohort population, it being in a practice. However you look at this, where people actually get paid for an achievement and necessarily get paid after a period of time. So you look now, people get paid, for example, to do a care plan. So a GP will get paid now to do the care plan, the largest sum of money, and they'll get paid then to see the patient on a regional basis, go and see them. They don't get paid. Well, what we need to do is change the focus, I think, to say, well, this is the care plan, let's at least go through this process, and when the process is finished, then we can understand some form of remuneration at the end of it. Now, that's not necessarily got the clinical outcome, but it's gone a long way from where we are at the moment, where it's the unit of care, and that's it. And you can look at that then for many, many aspects of care in the community, when really we should be looking at saying, well, these are the conditions in the community, these are the practitioners, be they general practitioners, physio, speech therapists, psychologists. This is the group of people that we need to bring together to get the best outcomes for the population, because if you do that, do it effectively, you'll stop people transitioning into a hospital system. And that's I guess the point I was trying to make earlier, that if we can get that outcome focus early, then we're on to a much more sustainable healthcare system. One other thing I would say about care in the community, I think everyone's quoting studies. Just one of our nurses works in we do a lot of work in delayed development. And so this delayed development can usually be highlighted in kindergarten. If you don't highlight it quickly enough, your capacity to catch up slows down. 60% of people in prison in the United States have delayed development. So we have to go back to the beginning and say, okay, what are we actually trying to achieve? How are we going to try to achieve this? And it really was all about outcomes-based focus at a community level.
It's a great question, the funding thing, because everybody's really struggled with it. So you have an NHS that pays a salary, that didn't work particularly well. Fee for service was to sort of drive throughput, and then we had people that abused that system. Just to talk about Salford Royal again in February when I visited with them, they're doing some really innovative work. And one of the things that's been put forward through the current government, which has been trialled, is particularly on older persons, is to say, what does a year of care cost? So what they're doing now is talking about a health economy. So they're not talking about episode-based funding, or even though it's there in the background, because that you've got to figure out a funding model, whether it's a RAF or a resource allocation formula or a case-based funding. Personally, I think it needs to be case-based funding, not a RAF, because you can't incentivise holding people in hospitals and not doing anything with them. I think you need to, But anyway, this year of funding, so how that works is, you say for an older person, and you can model this, you say with an older person who's 85 with diabetes, chronic obstructive airways, unstable angina, blah, blah, blah. What does a year of care look like? You say, well, over the course of that episode of care, they're going to have 3 hospitalisations, they're going to need a home nurse, sorting out their leg ulcer, you know, a couple of visits to a GP. That's what a year of care looks like. So then you assign that year of care to that individual. And then you get the GP. So what they've done in the UK is they've made the GP essentially the fund holder. So they give the money to primary care, and the primary care doctor purchases care on the behalf of that patient so that they get the right. Now, there have been problems with that, in that GPs have overhung onto patients in a way that hasn't been helpful. But people are struggling with this. I mean, the Dartmouth map stuff on the fee-for-service stuff is just extraordinary. You know, there's a place in Texas where if you walk through the door there, you're going to have a bypass. 80% of the population have had coronary artery surgery. It's nuts. You know, they're screening for it and they're recommending it. And the other trend in the US, fee-for-service medicine, which I think is just beautiful, it's a beautiful thing, is to operate on well people. How good's that? So you go, like my husband, he's played far too much sport over his entire life. In America, he'd go along, he'd have an arthroscopy, clean out the knee, a bit of you know, debris that's in there, split cartilage, whatever, his meniscus. They'd say, you need a knee replacement. The beautiful thing, operate on him. He's fit, he's well, he's going to be out of hospital quicker. You can do a lot more of it. I think it's genius.
Think she just wants her husband banged up in hospital.
No, I need him on rehabilitation.
It's more per capita out of any other OECD country on healthcare, and they have.
Oh, it's about you can say, you know, the American healthcare system is made up of multiple systems.
Yeah.
It's not a national health system, and you can go to systems like international healthcare, and it will just blow your socks off. They go from tertiary all the way to primary care. They've got the insurers involved. Invest any money that they save, they pour back into the system to pay for people to come in healthcare. It's just fabulous, but it's not replicated. Well, actually, for doing medicine, and now doing it in Mayo. So there's a few of them.
One of the things we were just talking about is, I guess, because analytics, we take the population and look and say, so what is this cost going to be? And we talked earlier, I think we talked a little bit about data. I think we've got some wonderful systems in this country, but we essentially have information systems that don't talk to one another. And whilst I'm a huge advocate for primary care, what we can do, the quality of data in primary care is poor. Really is very, very poor. Data isn't collected. That would enable us to do much more work in that area. And if you talk to health funds now about what they're trying to do, one of their biggest challenges is that their first piece of meaningful and accurate data is when someone goes into hospital. This is now too late. Yeah. We need to be able to model what people exactly, what's the 85-year-old patient. The big question is, so what does the 20-year-old patient look like who's 20 kilos overweight and so on and so forth? Yeah. What's the curve look like until they're 80? And what are we going to do now to change the curve? Because that's the secret. We have to change the curve because if we do nothing, a lot of this is about health literacy and all those sorts of things. We're educating people, getting them to take more ownership of their own health. But if we don't change the curve, then it does become unsustainable. Without the help of people operating on well patients, we have more sick patients.
That's right.
And we know what to do.
Exactly. And one of the barriers that's put up in Australia is that we've got this funding split. Now you're from WA, and I happen to know that in WA, in your remote home nursing services out there, what's that called? Anyway, that out there, they have pretty well designed that service as though that funding split doesn't exist. They've just ignored it. And what they've done is they've got the primary care, hospital service, just to pool that money together. I don't know how they've done it, but they've just pooled that money so that they've got enough money to treat the patients in front of them. So on one level we're saying, oh, you know, it's too hard to manage transfers of care and transitions and oh God, social care. But if you design a system and say, let's design the system as though that barrier wasn't there, and what does it look like, and how do we get people to collaborate and work together, it can be done. It can be done. WA must be able to do it.
if the US would do it in and out care, then that's taking one extreme to the other.
Okay.
Very successful doing
Do we have a question?
Talking about health and budget.
Sorry, do we have a question down the front here?
Yeah, so
Thanks.
that's a nice segue into the question that I had, Glenys Webbing from Blue Care. I'm interested to ask a question about the missing voice in the room, and that's the voice of the consumer, the patient, the client. And I think the WA example is a really good example because it's a very patient-centric solution, and transformation has happened from that patient-centred perspective. But the question that I've got for the panel is the role of the customer and their meaningful engagement a useful strategy that we haven't yet capitalised on in the Australian context for helping transformation to stick in health in a more significant way? And what are the global experiences that we might learn from in that particular space?
I think the short answer is yes. My experience is the hard bit is finding the right people with the right background and the right will. Most of them got a will, but are they representative of the services that are trying to the population for whom you're providing the services to, and you can get trapped with having the same people doing, I don't know what the experience is in Queensland, in WA, often it's the same people doing the same sort of thing, and when you really cut to the chase, they're not necessarily representative of the will of the people. And that still is, yes, and certainly we keep trying to do that, even to the point, again, I don't know what the situation is in Queensland, but in at least one of my services in my last job, we employed consumers. We went from consumer involvement to actually employing them, and whether that's unique or not, I don't know. But, so we keep trying, but I don't know that anyone is completely nailed the issue of are they actually providing the will of the community, are they representative of the community? And that's a bit controversial.
But yeah, we need to have it, for sure.
You need it.
For sure. We're just not very good at getting it.
I'd answer that question slightly differently. I would agree that the answer is yes. And if you take the fact that, as a fact, which I believe it is, our system as it stands at the moment has been designed for the benefit of the service provider rather than the service recipient.
Yep.
So, we build hospitals in a particular design because they're more efficient. We design super clinics because they do this in a more efficient way. Our systems are designed to funnel people to us rather than us to them. So, while that may have been wrong or no longer appropriate in today's context, I would argue that we can't throw all of that away. Because if we throw all of that away, then the total cost to system delivery actually increases. So I agree there are many systems around that are infinitely better than ours at the moment. And the client, the patient, the service recipient should be the centre. But I would just caution that, and I think you made a comment earlier showing that we'll always have hospitals. Unfortunately, there will always be people who are sick enough to warrant a hospital. So we might want to change some of that, but I think we just don't go, well, we can suddenly change the whole system massively overnight.
I'll go back to what I said and add a bit if I can. I don't think we should have a reliance on a small number of people being the consumer representatives around the table. We need to take that and add to it the voice of the people who have been provided with that service through whatever is a good mechanism to get that feedback, whether it's satisfaction survey, engagement surveys, or whatever. It's certainly needed to take the system forward, but I don't think there's a one solid solution to all this. I think we need to look at a range of ways in which we get information from and advice from and the experience from those that we're there to provide the service to.
I was just going to say, I mean, I think in some respects, we've sort of made this very hard for ourselves, because for everything we're saying we need to have the patient voice at the table, and obviously for some things it's much harder to imagine how we do that, particularly if you're talking about very technical operative procedures. But there are often other areas which are absolutely obvious, and certainly when you're talking about chronic and complex disease in older persons or even children with disabilities, it's absolutely clear that you have to have the family closely involved in the care delivery. So I did the end of life care for my mother in the UK, which is a great system. And, you know, up until the point somebody, because I insisted, scanned her brain to realise that she actually had a massive brain tumour, up until that point they all tried to tell me she was an old lady who wasn't doing very well. And I said, no. She lived in Australia a month ago and she was travelling independently. Something was very different. And at the point that when the diagnosis came through, I said, right, I'm taking her home. Everybody in the hospital went, oh, you can't do that. And I said, what? And they said, oh, you can't do that. I said, what do you mean I can't do that? Oh, it's far too dangerous. I said, what do you mean it's far too dangerous? I'm taking her home. It's too dangerous. It's not too dangerous. It's too dangerous to leave her here. And then I had to fight with everybody to say, I'm taking her home, including my brothers. What do you mean you're taking her home? See, I'm going to stay. Oh, that's fine. You know. But it was a battle then. It was a battle. And as my mum wanted to be at home, we wanted her to be at home. And the whole system, because she had a brain tumour, wanted her to be in hospital because it was unsafe. You know, and thank God for the palliative care team who stepped in and helped us negotiate that. But
I think part of that though goes back to before you get to that point.
sure.
And there is this different stage of life, you have different ways that you approach care with the consumer. I think you talk about sort of advanced care planning, that's something that can happen much earlier, and you can engage people in what their care is going to be. You know, they can come into an aged care home and say 65 or something like that, and you can talk to them and you can talk to their family in that process. So it doesn't become a reactive thing to go through when they get ill, because essentially it's almost the worst outcome. That if someone gets ill and someone says, "Oh, quick, transfer them to hospital," and it's, you know, they're coming towards the end of their life. So you take them out of an environment which they're probably they're most comfortable and most cared for. It's for me to put them in an alien environment, which probably isn't going to change the outcome significantly. But if you've gone through that process early with family carers, with those individuals much earlier, the outcome you get is much better. And it's actually much better for the patient because it's what they wanted. But if you want to look at the cost of the healthcare system, I don't know, you'll probably know it's 80% of their entire life cost in the last 3 or 4 months of their life. It's something ridiculous like that. And you ask yourself the question, for what?
Yeah.
What was that about? Nothing changed.
Yeah, you're assuming that the aged care provider will do exactly what the family wants and won't pick up the phone and ring the ambulance.
I think we have any questions on here.
That's one side, and end-of-life planning, and certainly my colleague Sarah, when she's done a lot of that, and I think it's not to pull it up. But the incremental increased potential life expectancy around exceptionally high cost drugs and technology, I think is actually the risk. And certainly the NHS has been struggling with this, and they've had a recent investigation or inquiry into very small incremental increase in cancer patients for new innovation drugs at exceptionally high cost under the current patency processes that we have internationally. How do you see that affecting healthcare? Because I think that's the scenario we're not actually talking about, because you can extrapolate quite simply into all the specialties if we're going on that side.
Yeah, Australia has a regulatory system in place to deal with that, of course.
But we have a media.
And the problem is the politics gets the politics very quickly. And look, if someone's got a solution to that, I'd love to hear it, because while you've got politics involved in the decision-making process, it's always going to be hard to say no to something that provides even incremental improvement in terms of longevity, the cost, and you could all experience that people have had in trying to say no. Then the lobbying really starts big time from the drug company, making efforts with the community and the politicians to get the decision over to them. you get around it?
Yeah. So one of the things is that Intermountain Healthcare, what it does is, it uses the 80-20 rule. So it simply says, what do 80% of people present to our facilities with and need to be cared for at home? And have we got those care processes right? Now, down the track, there'll be new therapies, gene therapy, and any number of things. And I wouldn't kind of advise people to get too far down that road with it because it's not here yet. But there is so much waste currently in what we're doing. Intermountain Healthcare works on 80% of its work is waste. That's what it's going after, the waste. That's doing things that don't need to be done, not doing things that should be done, harm, preventable harm, just letting stock expire, overstocking things and then drugs expire, incredibly expensive. Lack of standardisation of, if you've got an antibiotic, a generic, that costs a third of the price of anything else, and it does the same job, but why have you got 10 or 15 different prescribing regimens? And that's where they've gone after the cost-quality connection.
And I think
And
that's a really,
standardise it.
yeah,
And that's where the work, that's where we need to be.
it's a really important point because then you're talking about dealing with something you have some control over versus trying to deal with an MSAC or a regulatory process whereby you know the politics is going to get in the way. So go after the thing you've got.
The low-hanging fruit every time. I was talking to one of the colleagues who was around the blood transfusion.
Guys, I think we've probably got time for one more question, and then hopefully we can keep our panel for one drink afterwards so that you can maybe try and get a bit of one-on-one time with them if you can manage to. So do we want to just, has anyone got one final question? Sharon, what would you like to say? Have you got a big enough voice or do you need this?
I'm fine. I'm Sharon Lincoln, I'm working in the Gold Coast. I guess I want to take it back to the beginning when you talked about improvement science and that being the key to organisational transformation. And I'm just wondering, a little bit out there, you've got a really high-functioning executive, really focused on efficiencies. How do you make improvement science really attractive and easy to integrate? Sorry, that's not an easy one, but
Do you want to talk about it?
well, I wasn't get ready when I was asking that. Sorry.
Well, I think if you've got a hospital system that's only focused on efficiency or safety, on just one element of that, and they're missing massively. So you've got safety, you've got efficiency, you've got effectiveness, you've got patient satisfaction, you've got appropriateness. I think there's 6 that we're in quality care. So what we need to have is, if you're talking about a quality system, it needs to be looking at all of those things. Now, if you want to drive efficiency and improve, and usually if you improve efficiency, you'll improve quality, you'll improve safety, you'll improve customer satisfaction. The only strategy that's used over and over again in Australia, and it was used in the NHS and it was used in America, was to close services and queue patients. And you've got to be really efficient. Have you all seen the Westminster in the UK? Most efficient hospital in the world with 200 patients. Okay? So you can become incredibly efficient by simply closing services and queue patients. That's why government, having worked on government, state and federal, measures waiting times in ED, measures your waiting list, because it knows that's what you're doing to come in on budget. And it knows it will lose the election if those things fall out. Now, Intermountain Healthcare, we'll put that one up as it's been going the longest of this journey, if you like. It basically said, if we use clinical process improvement, and they had Edward Deming at their side when they did this, he was still alive, working with them on this, helping them design their programs. He said to them, if you work on process improvement, treat cost as an outcome of clinical work. Cost is an outcome of clinical work. He said there are 3 outcomes of clinical work. This is Deming. He said cost, adverse events, harm, and patient satisfaction. And for cost, we can look at utilisation. Right? He said if you manage processes, standardise, reduce clinician-led variation, and allow variation that is patient-led, which is at that 20% margin, They put in a whole system called mass customization. You will become efficient, you will become safe, and patients will be more satisfied in care. And that, 25, 30 years later, is working. And Barack Obama in 2010 said, we don't need a system like France or the NHS. We need the Intermountain healthcare system across. And then the Republicans had a party. But, you know.
Can I add to that from a really simple perspective? Accountability, performance management, and transparency. So all of the teams see all of the results.
Yep.
You're held accountable for them on a whatever you think is appropriate, weekly, daily, monthly cycle, and there is a consequence to the non-performance, and that's not a negative consequence, it's a what can we do to help, what can we learn from this. You do those three things? Follow that?
It's mountain, salary withhold, if you don't hit your targets.
And it really helps if you've got a burning platform. Because then you've got well, if you haven't got one, it just makes it a bit hard.
Thank you very much.
With the burning platform, you've at least got an opportunity to have the conversation with your clinicians and people with telephone. So this is our problem. We're going to get through it by focusing on all those things we're talking about today. It's not we're going to shut services. In this case, you're going to go back to it.
You can close services into queue patients.
Thank you so much. I think you'll all agree that we could stay here and pick the brains of the people all evening, but I know one of them's not very well and one of them has a long drive ahead. So